Thank you for inviting me. I'm happy to come and give you an idea of some of the dramatic improvements that have happened in the last few years in the treatment of metastatic melanoma, and maybe in the future we'll make moot the question of adjuvant therapy as we do better and better with metastatic disease. Those are my disclosures. So as this has already been alluded to, there are important driver mutations in melanoma. And this is a very simple diagram, things that we've learned in the last few years about what drives melanoma. About 50% of melanomas have a driver mutation in BRAF, 20% in NRAS, and 7% have a KIT mutation, which has already been discussed and is more frequent in the head and neck and highly sun-exposed regions, also in mucosal melanomas. And in about 23 or so, a quarter of the patients, they have either other driver mutations or they have mutations that we don't really understand. So the importance of those driver mutations is that they all activate this pathway called the MAP kinase pathway. And what happens is that with a receptor tyrosine kinase in the cell membrane, when it's bound by its ligand, this leads to activation of RAS, RAF, MEK, then ERK. And ERK activation leads to cellular proliferation. So this pathway is going on in all of our cells. It's one of the most common, most important pathways of activation in any cell. What we know is that in melanoma, several of these components can have an activating mutation, most commonly BRAF in 50% of patients. So when there's a BRAF V600E mutation, this constitutively activates BRAF, leading to constitutive activation of this pathway, hyperactivation of ERK, and increased cellular proliferation. We now have several drugs that can block BRAF, Vemurafenib and dabrafenib, both drugs that are FDA approved. This leads to rapid turnoff of this pathway with decreased ERK and decreased cell proliferation, in fact, cell death in melanomas that have an activating BRAF mutation. But in the context of head and neck melanoma, the BRAF mutation is fairly uncommon. More commonly, we would see either a mutation in upstream RAS or in a receptor tyrosine kinase such as KIT. But when we do treat these BRAF mutated melanoma patients with a RAF inhibitor, such as Vemurafenib, we see very rapid and dramatic responses. This is a PET scan, which is a little bit of a cheat, but it shows visually what we see by CT scan, patient with widely metastatic melanoma. And this was a 10-week scan, but in reality, if we had done a PET scan at 2 weeks, we would have seen the same thing. We see dramatic responses in all tumors at all sites, including bone, which we had not seen previously in melanoma. But as I mentioned, the RAF mutation is pretty uncommon in head and neck melanoma, and certainly almost never seen in mucosal melanoma. More commonly is a KIT mutation, which we've already discussed. These are data from a phase 2 trial done at Memorial by my colleague, Rich Carvajal. And we were able to identify 23 melanoma patients with KIT mutations and treated them all in a phase 2 trial with imatinib. First point is that it was hard to find 23 melanoma patients with KIT mutations. So the incidence of KIT mutation is relatively low. But even when you do find them, although we do see some responses, the overall response rate was only 17% in this cohort. And so the other thing we learned is that there are a variety of KIT mutations seen in melanoma and in other cancers. And just like in GIST, certain KIT mutations are sensitive to imatinib and others are not. So the take-home message here was that it's definitely worth looking for KIT mutations, but they are not as common as we thought, and certainly these imatinib-sensitive ones are even less common. But what I wanted to talk to you primarily was the revolution that has happened in immunotherapy in melanoma, because this is highly relevant to the head and neck melanomas, although the relevance of mucosal melanomas is still unclear. I'm going to tell you about two immunotherapy treatments. One is an FDA-approved drug called ipilimumab. This one, I'm going to give you a little bit of immunology, and I assume that many of you don't think about this very often. So I'll try and do this in a way that maybe will not glaze your eyes over. But on the left-hand side is a diagram of a T cell interacting with an antigen-presenting cell. And this T cell is seeing its antigen, which is in red, and it's binding to it through its T cell receptor, TCR. This antigen is typically presented in the context of HLA. But this interaction is not enough to activate this T cell. Actually, there needs to be a second signal, which most commonly is an interaction between CD28 and B7, which here is called CD80, CD86, on antigen-presenting cells. And when you get this first and then second signal, this leads to T cell activation, and it goes on to do its thing, killing what it's supposed to be killing. But also, we don't want that to happen continuously. We want there to be a mechanism to turn this off so that every time we fight off a viral infection, we don't get lymphoma. The most common way for this to happen is that the T cell starts to express a new molecule called CTLA4, which is in orange. CTLA4 then binds to the CD80, CD86, and this leads to a negative signal, turning the T cell off. The hypothesis had been that this was the problem in melanoma. We could identify T cells that could recognize melanoma antigens, but they didn't seem to do anything. So the idea was that, well, maybe these T cells are being turned off by CTLA4 expression. I should point out, in the interest of being fair, there really was very little data to say that that was actually the case. But still, this led Jim Allison to develop an antibody against CTLA4 to try and block this, to try and turn the brakes off of these T cells to allow them to become reactivated. And that's shown in the right-hand slide, where the antibody binds to CTLA4, blocks it so that the T cell now is free to have its CD28 bind and second signal reestablished, and the T cell becomes very active. To make a fairly long story short, we don't know if this is the actual mechanism for this antibody to work, but this antibody does work. I'm going to show you, this is one data slide for ipilimumab, well, 2 data slides. This is the first one. These are the overall survival results from the first phase 3 trial with ipilimumab, which led to FDA approval. In this trial, patients who had previously been untreated who had metastatic melanoma were treated either with ipilimumab or with a vaccine called GP100, or with both. The lower curve shows you the overall survival among the patients treated with vaccine alone. The other two curves, which are superimposable, are the ipilimumab arms. And you can see that the curves are the overall survival curves are shifted upward. And the p-value was highly significant. And this was the first clinical trial in melanoma to show an overall survival benefit against anything, which is why this quickly became FDA approved. Subsequently, there's been a second trial to confirm this. We use a lot of ipilimumab in the melanoma community, and at Memorial, we've treated over 700 patients with ipi one way or the other. There's been so many patients treated now that my colleague Steve Hody has been able to put together this pooled analysis of over 1,800 patients treated with ipilimumab. This is the overall survival curve of all of those patients. And the point here is to say the 3-year overall survival rate is 22%, which is much higher than we've seen in the 20th century with chemotherapy. But also you can see that this curve is plateauing pretty much by 3 years, and that 6% of the patients who are alive at 3 years are alive at 5 years. And we are seeing this in our clinics now. We're having patients surviving longer and longer. We have long-term survivors. We have complete responders. And we are now, for the first time in my career, sending some metastatic melanoma patients to survivorship clinic and no longer following them. So let me tell you about another immunotherapy that's already been mentioned, which is the anti-PD-1. This is, I apologize, another immunology cartoon, but here, this is similar to the ipilimumab story, but a little different. It turns out that tumor cells can protect themselves from T-cell killing by expressing molecules called PD-L1 or PD-L2. And these are shown, we'll see if we can. These are, I don't know if I have a pointer here, but which one? Here? I don't see it. I don't get it. Anyway, so here you see a T cell interacting with a tumor cell, again seeing its antigen, which is here in yellow. And what the tumor cell is doing is protecting itself by expressing PD-L1 and PD-L2. By doing this, there's PD-1 that's on these T cells. PD-1 binds to PD-L1 and 2. This causes a death signal to be sent to the T cell. The T cell dies. So this is kind of a cloak over tumor cells, including melanoma. So here the idea is adding an antibody to PD-1 or PD-L1, or in this case PD-1, that blocks this interaction to allow the T cells to survive this interaction and kill the tumor cell. So there are now 2 PD-1 drugs in late clinical trials. One's called nivolumab, one's called pembrolizumab. They're very, very similar. These 2 drugs are the newest thing. These are the things that are really exciting us these days. Because here's some phase 2 data from a pembrolizumab trial. Among patients who either had already had ipilimumab in yellow or had not had ipilimumab in blue, which didn't really make any difference. 72% of patients had some degree of tumor shrinkage, and there were some very dramatic responses with some complete responses in this phase 2 trial. Here's some long-term overall survival with a different PD-1 drug called nivolumab. Here the point to make is at 2 years, 48% of the patients were still alive. And at 3 years, it looks like it's plateauing. We're having over 40% of patients alive. So these responses can be quite dramatic with these PD-1 drugs, and they appear to be long-lived. So I wanted to end by showing you 2 different case reports of 2 patients whom I treated with head and neck cancer, in this case scalp melanoma, with these immunotherapy drugs. The first was a 62-year-old man who had a BRAF wild-type, NRAS wild-type melanoma, and it was excised in July 2011. He underwent a wide local excision with a positive sentinel node and was followed for a year when he developed seizures, found to have multiple brain metastases, and an enlarging paratracheal lymph node. At that time, we started him on ipilimumab for systemic therapy as well as the whole brain radiation therapy. And he was treated with the standard regimen of ipilimumab, which is for 12 weeks. And he developed a partial response, which I'll show you, but had also a common side effect of the ipilimumab, which was adrenal insufficiency, which turns out not to be a big deal to take care of. But here's what happened with his brain. The upper images are for the pre-whole brain RT. You can see 3 different brain metastases. And they responded pretty well, which we don't usually see with whole brain RT in melanoma. But there is this sense that perhaps with ipilimumab, radiation could be more effective. But more importantly, his paratracheal node improved. This is a diagram of the data showing over the weeks the tumor went down with the ipilimumab, but then at some point at around week 20 or so, it started to grow again. So what we did is, it was growing, but he also developed new aphasia with a new left parietal lobe lesion in the brain, so that was resected. But with the paratracheal node beginning to grow, which we documented by a biopsy, we started him on one of these anti-PD-1 drugs, pembrolizumab. He had a dramatic partial response, near complete response, and a biopsy showed no evidence of persistent disease. I'll show you this here in a graph showing the MK347 is the old name for pembrolizumab, and showing you on the y-axis the size of the bidimensional product of the tumor, the melanoma. And you can see that with treatment it went down to almost zero, not quite. Biopsy was negative, and he still, as of today, is still doing free of disease off treatment. I'll show you what these pictures looked like. In the upper panel is the lymph node pre-treatment, pre-pembrolizumab at 4 months prior to pembrolizumab. 1 month, you can see it's a little larger. And 3 days before we started, it's larger still with 2.5 centimeters. And then by 3 months, 6 months, and by 8 months, we could hardly even see it on the scan. But there was enough there we could see so that by endoscopic ultrasound-guided biopsy, we could get some tumor, and we could see this is what we ended up with, a couple of benign melanocytic vestiges, no active melanoma. Another patient, also 67, also with a scalp primary, had a deep non-ulcerated primary melanoma, wide local excision, negative sentinel lymph node biopsy, but this patient developed a Hodler lymph node, which was confirmed by biopsy. He was treated on a clinical trial where he got ipilimumab and either got nivolumab, the anti-PD-1 drug, or got a placebo. We still don't really know. But he certainly got ipi. And this is what happened to his Hodler lymph node. It went down to a complete response, and we actually tried to biopsy this, and this is negative. We couldn't really get any tissue at all. So he is continuing to get either nivolumab or he's getting a placebo. We don't know at this point, but because he's completed his ipilimumab. So this is my final conclusion slide about 21st century treatment of metastatic melanoma. We are now seeing long-term partial responses and complete responses, which pushing the overall survival curve. I think we are curing some patients finally. Immunotherapy is now or will be in the next year certainly first-line therapy for all patients with metastatic melanoma. And the other important point is that we need to genotype all melanomas to know whether there's a KIT mutation or a RAF mutation. Right now, if there's a RAS mutation, we can't do too much about that other than put them on clinical trials, which we have many of. But that'll become more and more important as we develop new drugs for these other driver mutations. Thank you for your attention.
We just have a minute or two left if there's any questions.
How are you? I wanted to ask you a question. I mean, I find it amazing that a disease as complex as melanoma can be controlled by inhibiting one pathway. I mean, to me, that's shocking. Because, you know, what we do, most of us here, is head and neck cancer. And we found that targeting a single pathway doesn't do anything. So how is it, I mean, how do you conceive that this happens? And I wanted to ask you how much resistance you see. I mean, after treatment, what are the outcomes? How long does it take to develop resistance? And what are you doing about that?
So in terms of the RAF inhibitors, it turns out that that pathway I showed you, the MAP kinase pathway, is absolutely required for melanoma. Melanoma is addicted to this pathway. And I think that's why, and I agree with you, it was a little surprising that blocking one drug, one part of that pathway had such dramatic effects, but it does. But it's so reliant on that pathway that it finds a way to reactivate that pathway. And so, unfortunately, with a median of 7 months, these tumors do become resistant, find a way to reactivate that pathway. And so what we're doing about that is combining inhibitors. So there's a RAF inhibitor, which I showed you. We're adding MEK inhibitors, which is just below it. We're also exploring possibilities of giving intermittent dosing, because we now know a lot about how these cells respond to RAF inhibition and develop feedback mechanisms to try and hunker down and survive this. So it makes sense to use intermittent dosing with high doses. So we're hoping that that will help. What's interesting is the immunotherapy doesn't seem to really have that problem.
Yeah, I think, and then there's the vaccinal effect and all these things that are going to make it even better, right?
Mm-hmm.
Yeah, thank you.
Can I just ask one final question with the...
Thank you very much for this interesting talk. Do you think there would be a possibility to use PET as an early indicator of treatment response or also early resistance so that we could monitor treatment and avoid futile, expensive treatment?
Yeah, with regard to the RAF inhibitors, what it turns out, and this is very, very interesting, PET is really not useful at all. And the reason is because when you block that pathway, you block FDG uptake. So everybody's PET scan gets better. So you have to really use cross-sectional imaging. You need CT scans. What we're looking at, and what other people are looking at as well, is looking whether we can follow circulating tumor-derived DNA. Since these have BRAF mutations, we can distinguish between normal DNA and tumor DNA in the blood. And we would expect, in fact, our data show that the tumor DNA goes away pretty quickly.
Is it the same case with the immunomodulating therapy, with the PDF inhibitors, do you think?
I think, but we don't know. We're looking at that right now.
Okay, I'd like to thank my co-chair and all the speakers for a very interesting section. Thank you very much.